happens when you have AFib, why do you have AFib, pathophysiology, mechanism, and definitions of different kinds of AFib, and then go over treatments and why we even get to AFib ablation at one point, and then review complications of atrial fibrillation ablation. So, according to the CDC, in 2010, they did a review. There's about 2.6 million people who have atrial fibrillation. And by 2050, it'll range between 5 to 12 million. So it's very prevalent. And then incidence increases with age. Also, we know that as the elderly population is getting, is living longer and getting older, so we're going to see more AFib through that way. But also our awareness of atrial fibrillation is there too. When you talk to patients, they're like, oh yeah, I had a grandmother who died of a stroke, or had a, but then you really figure out that all those patients probably had atrial fibrillation. Median age for a man is 67, and for females a little bit later, 75, and a lifetime risk of 25%. So when you reach the age of 75, 1 out of every 4 person has AFib. So it's that common.
Wow.
Okay. So what's the prognosis of AFib? AFib's worst thing is this risk of stroke, okay? And the risk is, if you go with age or with the risk factors, it increases as they get older. AFib's associated with doubling in mortality, probably because it occurs in patients who have other medical problems, and also because as they age, they have other, their mortality is higher. And we can see.
Mm-hmm. I'm good, thanks.
Really so also the decreased survival also occurs throughout, and it's not just here; it's worldwide as well. So it's the same epidemic everywhere. Keep going. Okay, so why do we have atrial fibrillation? Well, we think this is the reason you have AFib. For sure, the patients who are younger, who who are healthy young people, have atrial fibrillation because of these mechanisms, but there's definitely, there's a patient with pneumonia who has AFib, there's post-op patients who have AFib. I don't think all the mechanisms are the same. But for the purpose of the treatments we offer, this is the mechanisms that have been described, and it makes sense in the sense that it's been validated through animal studies and other cellular level evaluations. So we think that atrial fibrillation requires a trigger. So the triggers come from the pulmonary veins, which enter the left atrium and the posterior wall. And this is looking at the posterior wall here, looking at the back of the heart. And you can see the triggers can come from any of those 4 pulmonary veins, and they sort of start the short circuit of atrial fibrillation. And when you start short circuiting, then the heart gets used to it. Okay, so people who are symptomatic may say, I had AFib for 5 minutes and then it went away, or they may not even call it actually AFib, they call it palpitations. But then over time, the heart gets used to it, and it's actually at the cellular level that the heart changes its properties to get used to atrial fibrillation. Okay, all right. So there's different definitions for atrial fibrillation, and paroxysmal patients are the patients who are the earliest in their diagnosis of AFib, because the heart's not used to AFib. So they have AFib, but it only lasts for maybe a few hours, a whole day, but they convert to sinus rhythm by themselves. Okay, so they go in and out of atrial fibrillation. These are the patients who should get cardioverted, although we do have people who come through clinic because they went AFib last night, they have to get cardioverted because they can't live with AFib, right? You've seen all of those patients. So those are the paroxysmals. There's persistents, who are the ones who come in for cardioversion, because those are the ones who cannot convert by themselves. Okay, those are the big group of people that we see that, and those patients can be symptomatic, but a lot of times they just sort of feel tired, or it could be picked up by accident by their primary care provider when they went in, their pulse was high, and they were diagnosed with AFib. So they've progressed through their disease process a little bit longer, and their heart's used to being in AFib. So they need antiarrhythmic medications and cardioversion to get them back in rhythm. Long-standing persistent atrial fibrillation and permanent atrial fibrillation are pretty much the same. The reason we identify them as different things is because we choose to take people who have been in AFib for more than a year, for I don't know what reason, but we choose to somehow treat them and get them out of AFib. And then for permanent AFib, we've decided that these people are just going to stay in AFib. So that's the difference between, but essentially they're both the same, meaning that they've been in it for more than a year. So the one thing that's really important is anticoagulation with AFib. Like we said, the biggest risk patients with AFib have is the risk of stroke. So keep going. How do we identify who are these patients who need to be on anticoagulation? Well, the most recent iteration of our guidelines, the American College of Cardiology sent out for AFib guidelines, included this very comprehensive risk score, which is the CHADS-VAST score. And I hope that everybody's notes that you guys see has this written in there and the score number. And basically it includes people with LV dysfunction, and that includes an ejection fraction of 45% or less. So it's not severe, it's actually mild, less than mild to moderate. Hypertension is a risk factor. Age above 75 gives you 2 points. Diabetes gives you 1 point. If you've had a prior history of stroke, that gives you 2 points. Vascular disease, that includes coronary disease, aortic disease, peripheral vascular disease gives you a point. Age between 65 and 74 gives you 1 point versus greater than 75 gives you 2 points. And then if you're female, you get an extra point. Of course. They go back. Yeah, that's right. And the reason you get an always, right? We're special. So always. The reason that females get an extra, so if your score is 0 and you are a female, so that would be 1, right? Mm-hmm. Your risk of stroke is exactly the same as a male who's 0, okay? The reason the score of 1 for female is added is because if you're 75 years and older and are female, your risk of stroke is 12% versus 9% in a male, okay? So it just bumps you up a couple of points versus a male once you start accumulating points. So if you look over to the right side, you see there's about 73,000 patients, and the risk, if your CHADS-VASc is 0 or 1, your risk of stroke is less than 1%, so it's pretty small. But if you go to 2, it's between 2 to 3%, and that's where the guidelines recommend anticoagulation therapy. If it's less than 0, you don't need to be on anything. I mean, not less than 0. If you're 0 or female 1, you don't need to be on anticoagulation. If you are a 2 and above, definitely need to be on anticoagulation. And then 1s depends if you're a 1 or it depends on your discussion with the patient. Okay, thank you. So now here's there's some consensus statements and executive summaries. Keep going, those are just guidelines. Okay, so we have we identified someone with atrial fibrillation. We're going to give them anticoagulation. The next thing to do is decide, do they need cardioversion, antiarrhythmic medications, rate control medications, ablation? How do we decide? Well, we sort of try to talk to the patients and categorize them. Are they symptomatic or not symptomatic? Okay. If they have no symptoms and don't even know they're in atrial fibrillation, then they need to be addressed from an anticoagulation standpoint, and we need to give them a monitor and see what their heart rate's doing and make sure their heart rate is controlled and they're not 160 when they're sleeping, and that causes cardiomyopathy and congestive heart failure in the future. So once we've addressed that, those are the patients, that's the best care for those kinds of patients. But then you have the patients who are on the other side, who are very symptomatic, who can't go to work, who feel every beat, those are the patients that we start treating with antiarrhythmic medications, cardioversion, and ablation. Okay. And sometimes they don't have cardiac awareness where they say they have palpitations or AFib, but they feel tired and short of breath, so they manifest their symptoms in different ways. So you have to sort of try to figure out, and it's really hard because most patients we see have sleep apnea, they have coronary disease, they have congestive heart failure, they have all the other things that could cause them the same symptoms. So trying to figure out exactly what's what, and maybe doing one set of cardioversion in them and seeing if they feel better is a good way of knowing whether it's causing symptoms or not. Next. All right, so this is our guidelines, and so you have somebody who has atrial fibrillation, who's symptomatic, you want to maintain sinus rhythm, and these are the pathways that you go down. So if you don't have heart disease, these are the sort of antiarrhythmics versus ablation, and if you go across you can see the different antiarrhythmics that we choose to use, and we use them for different kinds of patients. We really only have 6 options for antiarrhythmics for AFib. So there's not that many options. Flecainide and propafenone, which are in the first box, are for patients with no heart disease, no structural heart disease, and they should be used in younger, healthier people. Dronedarone and sotalol are also in that category, so they can be used as first-line therapy. Amiodarone, dofetilide, and catheter ablation is second-line therapy. For somebody who has hypertension, we decide whether they have LVH or not, but if they do have substantial LVH with the wall thickness, then they can't be on anything, because antiarrhythmic medications are pro-arrhythmic, so they're sort of scared to give to patients who have the potential for having ventricular arrhythmias otherwise, which would be, as your heart gets thicker, like hypertrophic cardiomyopathy patients, they have a higher risk of arrhythmias. And then there's ablation. And if you don't have LVH, it sort of falls in the same category as no heart disease, so we go into that same thing. If you have coronary disease, the only 3 drugs that have been approved, actually 4 drugs that are okay to use in patients with coronary disease are dofetilide, dronedarone, sotalol, second-line therapy, amio, and heart failure patients are only amio and dofetilide, right, that can be used. If you go back one, I'm sorry. If you could see that amio is not first-line therapy, and unless you have heart failure, and it should only be used for a limited time because it has a lot of toxicities associated with it. And also, amiodarone is not FDA approved for AFib. So it's a very big deal, but it is in our guidelines, as you can see, that we can use it for second-line therapy in AFib. But the patients should just be like, okay, we'll see you next year, here's a prescription for amiodarone. There should be immediate treatment plans, and then plans to take them off amiodarone if you want to keep them on it. Okay, next slide. Thank you. And then this is the categories of the antiarrhythmics. So you have the 1Cs, which are for the healthy patients, flecainide, Redmol, or propafenone. And then you have the class 3 antiarrhythmics, which are sort of categorized into 2 different things. The potassium channel blockers, which are sotalol and dofetilide, both of which have to be started in the hospital. So we hospitalize them, start them on dofetilide or sotalol, and then they come down for cardioversion. You may have seen those patients. And dronedarone and amiodarone are also class 3, but they have a lot of different channels that they affect. So I think that's stuff, because it's every channel.
What's the other name for dofetilide?
Ticasine.
Yeah.
Okay, sorry.
Yeah.
Ticasine
Thank
is
you.
the brand name. Dofetilide is the drug name. Okay, thank you. Okay, so does that make sense so far? Questions? No. Ann?
Good, thanks.
Ann could give this talk better. So now these are the most recent guidelines for AFib ablation, and this was published in 2012. So indications for catheter ablation. If you have, so class 1A indication is someone who has paroxysmal AFib, someone who's symptomatic paroxysmal AFib, okay? So symptomatic AFib refractory or intolerant to at least one class 1 or class 3 antiarrhythmic. Does that make sense? So they fail, and you saw, remember that chart? You fail an antiarrhythmic, or you're intolerant of it, I don't know, you took it and you passed out, and then the next thing is ablation. It can be offered. If you're paroxysmal, it's a 1A, because those are the patients that we have the most success with ablation. Persistent is it's reasonable, and it's a 2A, so it's not as good as 1. You're familiar with the classes, right? 1A is the best, 2A is good, 2B is also okay, and then 3 is contraindicated. And then so if you move down, symptomatic AF prior to initiation of antiarrhythmic therapy is a 2A. So actually, if someone comes in and says, I don't even want to take medicine, you can offer them ablation, but it's a 2A indication. Okay, so just a quick before we talk about ablation is the development of AFib. So we said it requires the trigger, which is where it's coming from with pulmonary veins. It also requires the substrate, which is the left atrium, to sustain AFib, right? So the trigger starts, but it requires that heart muscle abnormalities that it sustains over time to be able to have atrial fib. And the goals of atrial fibrillation ablation are to prevent AFib by either eliminating those triggers that are coming, that initiate it, or by altering the substrate, the arrhythmogenic substrate, which would be the left atrium. And it does improve quality of life, like we talked about. Improved survival has not been shown in a randomized clinical trial. Okay, so you can't say you need atrial fibrillation because it's going to make you live longer. It doesn't. That's not the case. It's really a symptom driven procedure. Okay. So I was going to talk about a patient and then go into complications of the procedure itself. So 45-year-old gentleman with symptomatic paroxysmal AFib. His symptoms include palpitations, fatigue, shortness of breath. He's on beta blockers, flecainide, 100 milligrams twice a day, and he has recurrent symptoms. 4 episodes of atrial fibrillation that last greater than 3 hours in the past month, and other episodes are very frequent throughout the day. His medications include aspirin, metoprolol, and flecainide, no other past medical histories, and his physical exam is normal, other than having irregular heartbeats on his hand. So before we, okay, keep going. So what are you guys thinking about this guy when you hear about him, his history? Any volunteers?
Well, he's not, and he's on no anticoagulation because his score's probably 0, isn't it?
Yes, and we'll talk
He
about
doesn't have
that.
any
Good, 'cause
history.
that's the first thing you think about is, yes, right, and we'll talk about that. But as far as treatment for AFib,
He's on a beta blocker, he's on flecainide.
and he's still having symptoms, right?
So
Okay.
maybe the second line, yeah.
Right, okay. So here's his EKG, and it looks like he's, as you can see, he's in AFib here, and then he goes in sinus, and he's in AFib here. So he's constantly going in and out of AFib. Okay, go ahead. So anticoagulation, is aspirin adequate for him? Does he need oral anticoagulation? How do we decide? Next slide. And then this is sort of the, okay, I'm sorry. No, go back to this. Somehow that other slide got stolen out of it. Okay, no, the anticoagulation, sorry. Keep going forward. Perfect, so, how do we decide what he needs to be on his score? And then go back to the history. Thank you. All right, so he's 45 years old, he's not 65 or 75, so his age criteria. He's otherwise healthy, he doesn't have hypertension, diabetes, congestive heart failure, and he's just probably Chas vascular 0, so he gets to take nothing or aspirin, okay?
Do you put him on aspirin if their score's 0?
Okay, so that's a good question, and I guess most people do. But there's, of all the studies, well, there's only 8 studies that actually got completed for aspirin. Only one of them was positive for aspirin versus nothing. So it does have risk of bleeding. There is risk of bleeding in those kind of medications. So it's a toss-up, and I bet in the next set of guidelines that comes out, it may not even be included in there, because the new agents that we have are so good that we used to sort of favor antiplatelets, but that's not the process that prevents stroke. And so it probably is good because some other people have other things going on, or vascular strokes, not cardioembolic strokes that may be helpful for us. So. Okay. So he's symptomatic. He has palpitations, fatigue, shortness of breath throughout the day. And then go back one slide. So if you go down, he doesn't have any history. He's already on flecainide and he's having symptoms. So the next thing is amiodarone, Ticasin, and ablation. So if I saw him, I would say, we can hospitalize you and give you dofetilide if you like. It doesn't work well for paroxysmal patients. It's more for persistent group of patients. But I would say, we could certainly try catheter ablation. But you always want to try another antiarrhythmic because they may, some people don't want to have a procedure done. Okay, go forward. Yes. Okay, so he decides to have an ablation done. And basically this is a cartoon of what we do. So we go through the leg, we go through the femoral vein on both sides, and we end up on the right side of the heart. And we do 2 transeptal punctures, going over to the left side of the heart. And we have one, the reason we do 2 transeptal punctures.
Sorry, I don't know what
It's an easy one to find. So the circular catheter actually looks at the electrical potentials in the veins to see if there are electrical potentials. And then the other catheter is the ablation catheter that gets rid of the signals, and that's how we do the ablation. Does that make sense?
Mhm.
Okay, next slide. Okay, so this is looking at different views, and these are the different catheters. That's why they have probably 4 to 5 access sites that you see. The long sheets are for the transeptals. One of them is usually a steerable one, which is the Agilis one that we use, and that what we use for the ablation, so we can get around to the atrium easy. And then we usually use a Schwartz catheter with it, which is an SL1 or an SLO, to get to the transeptal with and put the lasso catheter through. So that's what it usually looks like. The other thing is this catheter looks at the coronary sinus, which are the left atrial potentials. We use it to pace the atrium during the procedure. It also helps if there's atrial flutters or other kinds of things going on to see where, if it's on the left side or the right side. It sort of gives you, a visualization of where all the electricity is coming from. And then you have on REO, you have the His catheter, which looks at the AV node and the His conduction, and if you can advance it into the ventricle and pace the V if you need to. And then you also, so that's it really and then you have an ultrasound catheter, which we use for transeptal and looking at the left atrium and looking at what's going on throughout the procedure. If you go back, you can see in the background, there's a barium swallow there, and that's where the esophagus is, which is very close to everything we do. So we used to do barium swallow, but now we use a temperature probe to monitor the temperature throughout the procedure. It outlines where it is, but also if the temperature goes up, we remove the catheter and we don't do ablation in those areas. We try to accommodate by going to different sites. Next slide. Okay, so this is what it looks like. So at the very top, so this is very fast EKG going. I mean, it just looks like the heart rate is 0, but it's going at 200 speed. So your EKGs are at 25, this is 200, so it's just moving really fast, and it's so that you can see the details of everything that you're looking at. So the surface is the 1-2 AVF and V1, and that sort of spreads out electrically. We pick out those for a specific reason. Then you have, and this particular thing, you have a right atrial catheter that looks at the right atrial signals. Then you have the His catheters. You can see those little guys up still. And that looks like at the H, which is this thing right here, and the V. Forgot a pointer, sorry. And that looks at your His AV nodal conduction. And then the lasso is in a pulmonary vein. So you have 2 potentials there. One's the A, which is the first one, and the pulmonary vein potential is the sharp that's right next to it. And then you have the transeptal catheter, which is the ablation catheter, and the coronary sinus. Remember, that was the catheter in the left atrium that looks at left atrial potentials.
Wow.
So in sinus rhythm, the first atrial potential is coming from, if you look in line, right below the P wave up there is the right atrium, right? Because that's where the sinus beat starts. And then the next one is the His, and the proximal CS, they're sort of right next to each other because the CS os and the His are in the right atrium still. And then the later atrial signals are in the CS distal, right? So those are the first 2 beats, those are sinus beats. What happens in these last 2 beats? Where does the earliest atrial signal start? Everyone hasn't looked at this in forever, right? So the earliest starts in the lassos, right? You see those, it's the earliest signal that you see right here. And so these are PACs coming from the pulmonary vein. And that's how AFib starts. It starts that way, and then the heart starts.
It's irritated.
Yep. Okay, next. And then so there's a sinus beat there, and then there's another sinus beat, and there's a PAC coming from a pulmonary vein here. This is the earliest connection site to the pulmonary vein, and then it starts AFib. Okay, so that pulmonary vein is in AFib. Go back one more. Okay, that was it. Okay, next, I'm sorry. Thank you. And then here, what do you see here? This is like EP 501, whatever that would be. So what do you see on surface?
Sinus.
Perfect. And then, and what do you see in the lasso?
It's very fast.
Yes, so perfect. So the pulmonary vein is in AFib and the patient is in sinus rhythm. But you've isolated the pulmonary vein, so the vein is going in AFib and the whole rest of the heart is in sinus rhythm.
You can do that?
Yes.
Yeah. Really?
Yeah. And so this is why we know that the pathophysio, you can sort of prove what your thoughts are, and this is what, because it is coming from these areas.
So why does that rate not supersede?
It's not connected anymore because it was disconnected. So we disconnected.
Oh, you've ablated.
You've already ablated.
Oh,
Yes.
oh,
Yeah, this
oh.
is after ablation.
Oh,
So
oh, okay.
the veins in AFib. It has exit
I
block,
gotcha.
right? It's not
Yeah.
coming out of the thing.
Okay.
You're right. Why isn't it coming? Yes. Okay. Next. Okay. And so we use two different mapping systems. One's ESI and one's Cardo, and they have different magnets, different patches, different types of things that we use. But before these patients have this procedure done, they have a CT scan done, so we know how many pulmonary veins they have, where they're located, what they look like. We also do a real-time electroanatomical mapping at the time of the procedure, which is the thing on this side on the left. And then that's the CT scan. We can either merge it together or we can work with them side by side. And that way we know there's a pulmonary vein, the right middle pulmonary vein is not missing, or we can see if there's stenotic lesions or whatever it is. It's a very good thing to look at. And then we do the ablation, and those are the points, the red dots that are on the picture on the map there.
And that's what Ann is booking when she sees the patients over in the office. You guys ever see the CT scan? That's what she's doing for.
Oh, and those brown dots are where the esophagus was marked on this particular patient. Okay, next. Keep going. And those are just the lines, how we go point by point. That's why sometimes it takes so long. Well, not sometimes, it just takes so long. It's very tedious. Everything the interventionalists do are very quick and then the EPs are very meticulous and everything, it's just the exact thing of looking at these tiny potentials and making little points. I mean, we're the complete opposite, things. Okay, keep going. All right, so that patient had pulmonary vein isolation, and he's still doing really well off medications. And only takes a baby aspirin, so he's doing really well. So for this kind of patient, this procedure was perfect. Keep going. Okay, so complications with atrial fibrillation. How much time do we have? Are we good?
We're good.
Okay, okay. So we have, any questions so far? Okay. So there are things that happen at the time of the procedure, okay? There are thromboembolism or air embolism. We have two sheets across the left atrium. And we have to be super careful that there's no air going in there because that can cause VF and hypotension, all those things. We also have these patients on blood thinners. Okay, so they're on so we have 4 blood thinners now. We have 3 new agents and warfarin, right? And what we do with Ann is we either decide to switch them to warfarin if they're on a new agent, or they continue with warfarin, or if they've never been on anything, like that guy who was 45 years old who was on aspirin. He did get switched to warfarin. They have to be on a blood thinner for the procedure. These are the indications, but then you have to do it. So when they are on blood thinners, we ideally want them therapeutic at the time of the procedure, which is crazy, right? I mean, we want them to be between 2.0 and 2.5 for warfarin. And so the new agents, we don't have immediate reversibility capabilities with them. So there's been studies looking at the 3, Xarelto, Pradaxa, and Apixaban. And Xarelto had some positives. There was one positive studies where they gave it the night before because it's a nighttime dose. You don't take it in the morning, and then you give it the night after. So there's one study there, but it's one study. It doesn't supersede all the experience with warfarin. Pradaxa has also been used but interrupted, where you give it, maybe you stop it 2 days before and then you don't do a time of procedure, but we know from studies that if you interrupt anticoagulation, there is a higher frequency of strokes and thromboembolic events during the procedure. So that concerns me, if people are doing that, but they'll do what they want to. And then apixaban, there's no studies. So Xarelto is really the only one that you can do this with.
And the reason for the anticoagulation
It's
is
because of this. So you have catheters and wires and everything's in the left atrium, and we do start heparin as soon as we start the procedure. Not start heparin, but give heparin bolus, keep the ACT between 300 to 350. So you have a therapeutic INR and you have an ACT at 350. So you are, and you're in the left atrium, which is a very thin wall chamber. So you have to be super careful when you're doing ablations and doing all these things. So embolism is a big thing, and we irrigate the sheets during the procedure. We add, make sure they're clean, the side ports, and really that's it. So and then cardiac tamponade, as you guys know, it's acute hypotension and tachycardia. That can happen at the time of the procedure. It can happen in the holding room post-procedure. It can happen a day later. And sometimes with the new agents, I worry that it could happen later. Like if you've had some inflammation of the atrium and pericardium, you may bleed more because somehow warfarin is not as potent as the new agents. I don't know. I mean, we'll see. We'll learn more about it as we go on. But so what do you do when you have cardiac tamponade? Well, if you're in the lab, you want to reverse the ACT quickly with protamine or blood products. You also want to reverse your therapeutic, whatever agent you're on, and if it's warfarin. So those are the quick things. Fluids, because you want to increase their intravascular volume, and then they need pericardial centesis. So the risks of having cardiac tamponade or cardiac perforation is 1 in 1,000. That was based on a 10-year, the entire country's database of atrial ablations. That was published in 2007, and half of those patients need open heart surgery for correction of the perforation. So so that would be left atrial perforation. Like they don't stop bleeding, they just.
And that's from burning. Is that from?
It's usually not from burning.
Okay.
It's usually, so the most times this happens is during a transeptal puncture, because you're actually sticking a needle in the heart and going across.
And you go too far.
Well, so you're visualizing it with ultrasound. You can go more posterior and hit the posterior wall. You can go anterior and hit the aorta, and all these different things that makes me sick talking about it out loud. So we try to go through the septum to the left atrium. The other part is if just manipulation of catheters in the left atrium. Again, you're fully anticoagulated on 2 agents, and it's a thin wall. Yes.
So would the treatment in the holding area be the same?
It would be the same, yes. Okay. So you want to, obviously, it's
fluids,
emergent fluids. And we have some vitamin K and protamine. We probably want to store that in the holding room so that we're quick. We have them in the lab, but we should just
Get
be able
some.
to.
You give, at the end of these procedures,
Yes,
correct? You
we
give
do.
protamine.
Yes, so we do give protamine. We get their ACTs below 200 to pull the sheets.
Right.
Yes.
So at least that part.
Yes, but I may give more. I may want to check the ACT again, and if it's 190, give more. You want to get them to like 120, 130, if they're bleeding. So
the bleeding mainly, if it perforates, it's always from going transeptal, not from the ablation itself.
So transeptal is the most common, but there's many different reasons why you can't have it. One would be, it could be your right-sided catheter. We just don't know what, but the most common thing is during the transeptal. But definitely you can have perfs in the left atrium with catheter movement. We all do the ablations a little differently, but there's things that you know about not to obviously push or go to certain areas, and we use different forces. And like the posterior wall, we use less energy than the anterior wall because it's a thinner wall, but it's also near the esophagus. So there are things that we know how to do during the procedure to prevent what you're talking about. Because you're thinking ablation, burning, you poke a hole in the atrium. Is that what you're saying? That's not usual. That's not normal. That's not the case. these ablation catheters are 4 millimeter or 3.5 millimeters, so you're causing that big of a lesion, 3.5 millimeters. It's pretty small. And so that, any questions about that
How do you handle your stress?
during the procedure?
Yes.
Yeah. So the next thing is pulmonary vein stenosis, which isn't anything that's acute. It's long-term, it's, it takes, it could be 3 weeks later, they'll call and say they're short of breath, and then we sort of have to look into the things. Or it could be that it happens, 3 months later. So it's nothing acutely that I could see that would be a problem unless a clot forms in the pulmonary vein, from something acutely, which, we'd have to look into it, but that's where, so pulmonary vein stenosis is actually structural narrowing, and that happens as it heals. So this used to be pretty prevalent, about 2 to 3% of the time we saw pulmonary vein stenosis, and then, because what they used to do is actually do the ablation in the vein, but now we come out and we do the ablation in the atrium of the veins, and we make big circles, so we're not even in the vein, so that the risk of pulmonary vein stenosis is much lower now. Vascular access related complications, hematoma, pseudoaneurysm, maybe fistula, that's all, all that. We try not to we avoid the pseudoaneurysm and fistulas by not putting any arterial sheets in the leg, we just do the venous. And they're so overly anticoagulated that, they'll have a little bruising, but I use ultrasound to get access, and I think most of us do, so they don't have the complications. And going away with the Lovenox bridge that we used to do, there's so much less bleeding complications as well. So the arterial line, the anesthesiologists get in the wrist, so we have an art line, and you guys may want to just keep that while they're, probably I would pull it before they go to the floor. Maybe just keep it so you have an art line set up and watch. That's like the best thing to look at. I don't know why you would take it out before, And that's the other good thing that's in the wrist, because you can get hemostasis here, you're done. Your ACT doesn't have to be, 150 or whatever it needs to be for an arterial sheath. It can be higher for a venous sheath, and then this can come out later before they go to the floor. Atrial esophageal fistula is everybody's nightmare. It happens probably, I would say, in that study it was 1 in 1,000. Maybe the frequency has changed over time as we've used different tools. The fistulas it's a connection between the left atrium posterior wall and the pulmonary vein and the left atrium. So, I'm sorry, the esophagus. So the esophagus and the left atrium sit next to each other, and it's a connection. So you end up with fevers, sepsis, you can have a stroke, whatever you ate is in your brain. I mean, it's just awful. And these patients mostly don't make it unless you have quick response, home to OR type of thing. And we have those surgical repair, yes. We've had, we have a whole protocol in the office where they call even after hours, where they're triaged very quickly. And they call one of the ablation doctors if there's a question, if the question list gets to that point, whenever it does. So that's something that that doesn't happen immediately again.
So
No.
would that happen in the holding? Like what?
No.
Okay.
No, but that's just something that can happen.
Like 1 or 2 weeks post-op?
Exactly, up to a month. It's
Oh,
seen up to a
wow.
month.
Is that why they're you put them on like Carafate?
Yes, Carafate and Omeprazole, we wanna
yeah.
make sure they get it, they start on that
That
night,
makes sense.
and that way they coat the,
Right.
and I have pictures, we'll go through pictures.
Okay.
I just wanna make sure we include everything left atrium. So post-ablation, you can have recurrent AFib, of course, but you can have other flutters or atrial tachycardias that can form from the ablation sites. You can have mitral valve trauma, that lasso catheter, you have to stay away from the anterior left atrium because the valve is there, the mitral valve, and so you could see that you would get stuck in there. And so if you see somebody hemodynamically compromised, an echo is helpful because you can make sure you don't have flailed leaflets or anything from the procedure. If you did that, but usually we were aware of those things during the procedure. Phrenic nerve injury. Phrenic nerve sits right by the right superior pulmonary vein. So the reason we chose not to do the cryoballoon ablation, which they do in other centers, is that the risk of that particular thing was about 14%, so it's pretty high. And then radiation exposure, skin burns, we're using less and less radiation, so we're not seeing those. Acute coronary occlusion can happen, very rare. And then periesophageal vagal nerve injury if people have difficulty swallowing. Okay, next slide. Sorry, that one took forever. So this is a transeptal, and you can see there's a clot on the ultrasound on the septum, so that's why we keep the ACT so high. Next. This is, you can see what that is, right? Tamponade there, and it's squeezing the heart.
Oh, yeah.
Okay, next. And you see they're tachycardic.
Mm-hmm.
Okay, next. And then we talked about pulmonary vein isolation. This is a lot of detail that, you know, if they need stents or angioplasty of that. This is all late stuff. Next. And this shows what it looks like when there is stenosis. You know, there's narrowing right here. You see how narrow that is. And usually they're not symptomatic unless they have three or four pulmonary veins that are stenosed. So if they just have one, then they're not symptomatic. Next. You can see how narrow this, see that?
Mm-hmm.
Okay, next. And again, another picture of narrowing. You can also, if you see that, and you are trying to figure out, well, does this affect anything? Is this what's causing shortness of breath? And then you could do a VQ scan and see perfusion defects in those areas of the lungs. Next. Okay, so this is the AV fistula, less than 0.25%, 2 to 4 weeks after ablation. Common symptoms are fever, chills, neurological events, septic shock, or GI bleeding. CT scan, you don't want to do endoscopy, you don't want to stick more stuff in their esophagus. Most patients die if they're not recognized.
So let me ask you this, the symptoms there, I mean, I've never educated, well, I mean, we don't discharge them, but is that information supplied to the patient?
I tell them, we tell them. We tell them before the procedure. I mean, this is the conversation that you have with them. That's why, we don't want them to show up the same day. We spent so much time learning about the patient and trying to make sure they understand that, yes, this is a symptom relief procedure, but there's real life complications associated with it. I mean, it's like any other procedure. There are these bad things, but it is scary. And so they know about.
Is that reiterated on their discharge from 6A after Saxonhouse, do you know?
Do you ever feel, I don't know if there's different nurses that discharge.
And Yvette doesn't see
We haven't put
them.
together that discharge instruction sheet.
I had that and I forwarded it to you and they were gonna use it out it.
Did you think they used it? I don't think they're probably using it.
I don't know.
Okay.
Maybe that's something to look into.
I'll forward one to you.
Okay.
How about that?
Gotta go through all these forms committee, but we'll work
So,
on it.
left atrium and I bet you that's where, I know Robin has it. So there's the left atrium and there's the esophagus, right here, that's the esophagus, left atrium. And you can see there's a little fistula, I mean, it's really hard to see, but I guess radiologists can see that. Next. And again, look at where the esophagus is, right, sometimes you even see indentations in the left atrium from the esophagus.
Wow.
Okay, next. So, here's a fistula, and you can see that, there's like air in the left atrium. Okay, next. Here's, the fistula between the left superior pulmonary vein and the esophagus. They're showing the fistula, that big opening right there. And again, so if you go back, this was things that would, I'm sorry. If you go back and look at your map and sort of line up what happened, this is where they did the ablation line right there. And that's where the fistula occurred right there. Okay, next. And then we talked about phrenic nerve being right next to the right superior pulmonary vein, so we have to, if we go in the vein too much, we should pace and make sure that we're not capturing phrenic nerve before we do ablation. But we stay out here when we do the ablations, so we're not in the vein. Okay, next. this is esophageal ulcers, and it is thought that most people develop these, just a little bit of irritation in their esophagus, that everybody develops, and that's why we use the carafate and the omeprazole. Next. That's just, again, proximity of esophagus to, okay. Keep going. I just had a bunch of stuff. This is, this is a long time ago when there used to be radiation burns, and these things never heal up. They keep coming back, okay. Phrenic injury again, and you see the diaphragm is up. I just put a bunch of pictures in here from them. Okay, so when do we repeat ablations? When do these things recur? So success rate for somebody who has paroxysmal atrial fibrillation is about 70 to 80%. Okay, and those patients, probably most of them are much better. The 20% are much better than they were. So either they're controlled now antiarrhythmics, or they're not as symptomatic, or they may have it just once a year instead of 3 times a week. And so they are, but there are several patients that we bring back, for repeat ablation. They may also have other things like flutters that may have formed from the procedure that we do. Next. Okay, so in conclusion, we have AFib is a common diagnosis, and there's a very, we talked about millions of patients with AFib, but that we're talking about a very small subset that is AFib ablation candidates. Anticoagulation is important, like we talked about, that needs to be addressed separately from the treatment of atrial fibrillation, and then understand the complications of AFib that can occur millions later for all source, so it is a pretty invasive procedure. AFib does recur in some patients despite ablation. So it's not a cure, and that's something that patients need to know. It can recur. That's it. Oh, next slide. This is our AF center at CHS. So we have, Anne runs the whole thing.
Yay, Anne!
Yes.
With the AFib persistent and permanent, they're basically the same, you said,
So persistent is,
over greater than a year.
so persistent is, more than 7 days, permanent is more than a year. Long-standing persistents are also more than a year. And the difference between the long-standing persistent and the permanent are that both of those are the same, except one, the long-standing persistent, we want to maybe do something to them, maybe do an ablation or something, that sort of.
So one is maybe because they're more symptomatic than permanent, or worse?
Yeah, I guess, yes, yes, probably, right, yes.
And then why would the ablation not, I know it does the quality of life, but why wouldn't it also live in life because you're decreasing clot potential, right?
Very good.
Stroke potential. whatever you
Great
wanna call it.
question. The reason, but what I said was it hasn't been proven in a randomized clinical trial, so we can't do that. But we know that one of the largest clinical trials, which was the AFFIRM study, looked at patients with atrial fibrillation and how they were treated. There was 2 arms. One group was the group that was in AFib all the time. They didn't do anything with them. They just put them on blood thinners and control the heart rate. The other group was the group that had antiarrhythmics, cardioversion, ablation, whatever they had done, but they're maintaining sinus rhythm. And so at the end of the day, they had no difference in mortality, and the only difference was that the stroke risk was a little bit higher on the patients that we kept converting in this group, the sinus rhythm. And the reason was because patients were being taken off anticoagulation even though the risk score is higher. So even if you have an ablation done and you don't have AFib, if your CHADS VAS score is above 2, you still need to be on blood thinners, and that's part of the guidelines.
And that's just for AFib, because let's say you have a CHAD score just because, right, the CHAD score is not just for AFib, it's just your cardiac risk score, correct?
No, it's for AFib.
Oh, it is?
It's for AFib, risk of thromboembolic stroke,
Okay.
or
Okay.
thromboembolic events. AFib, yes.
And then when you're in the procedure, how do you determine whether you're gonna overlap your mapping system or not?
It just, you do the same thing every time, it depends what your preference is.
Oh,
like I merge them together, I don't know, other people may not, it just depends on what you decide to do. It doesn't have any patient-specific things. Although sometimes if they were in AFib when they have the CT scan, their volume's bigger, cause they're not squeezing, and then at the time of the procedure, they're in sinus rhythm, you merge them, they look off, and then you don't merge them, so that is one reason why we don't sometimes merge them.
And with the risk for the esophageal erosion and stuff, are these patients put on meds prophylactic before? And is there any study that says that it?
No.
No? If
I
you
don't-
do
I'm not
that,
aware
it
of that.
lessens their
I'm
likelihood?
not aware of pre, but post
Yeah.
is beneficial.
The volume of these procedures seems to be increasing. I mean, Ann's booking them up until what, December?
You're full.
Yeah.
You're full. You got one left, you got one opening.
Really,
Till
you could do
December?
this
Till
5 days a
January?
week, huh? I mean, really,
Yeah.
is that right? I mean, they could be doing these 5 days a week?
Yeah, so they do get a TE the day before, so we've tried to organize the lab so that we do them certain days of the week. So right now, we're doing them on Tuesdays, Wednesdays, and Fridays. And we used to do them Tuesday, Wednesday, Thursday, and they've not do Monday, Friday, but now we only have one person allowed on Thursdays, so those are the days that we're gonna be doing them.
And they get a TE, a CT scan ahead of time in all the education.
Yeah, so it's very organized now. They come in, they see us, then they see Ann. Ann schedules all of them, and she is like incredible. She does the, she talks to them forever, and then they get scheduled for a CT scan. Then they do it the day before the procedure. They have their labs done, their TE done, their INR checked. They see a EP/ACP, and they get their H&P done. So they have the procedures come in and say hello and go to the procedure room. They already have their 1-week follow-up with ACP scheduled before the procedure. So they're seen very quickly after to make sure there's no problems there.
So is it, I've been in the cath lab a long time, we used to do these procedures without anesthesia, did them a lot. And now, over the last couple of years, it's all with anesthesia, I think
Yeah.
that's a good thing.
And I think
Is that like a standard now?
Yeah, I mean, I think so, yeah. What's driven this, first of all, it's good to have some routine and do the same thing over and over because it creates less variability. And the same thing, like you come to work, right? You don't walk a different way to you know, because then you're gonna get lost. Like, you know, can't find this place. But the problem is that so you can have anesthesia where they're sedated and they're so they're comfortable for the procedure. I mean, there's not much pain associated with it. It's just annoying to lay there for 5 hours. It's ridiculous, actually. But once you sedate them, then the whole thing was, okay, so should we just do propofol sedation? But then you're putting an esophageal probe to measure temperature, and then their airway is not protected, so now they're all getting general anesthesia.
That makes sense, especially with that probe.
Yeah.
But is it Dr. May that, he still does, he does not intubate.
Yeah, maybe, I mean, some people
Yeah.
have different preferences, it's whatever he's comfortable with. He might use the CT scan esophagus, on the CT scan to and bring it over and know where it is, that's where he
Versus the
looks
probe.
at it, yes.
Oh,
The
okay.
probe versus the probe, so there's different ways of doing things.
And
I
the
just
probe
sort of-
is measuring temperature,
the
correct?
temperature and like yes, so if it's 36.4 and it goes to 36.5 and I'm on the posterior wall, I stop.
Okay.
So very, just to make sure there's no,
And this is all burning, correct? This is
It's
not
not-
freezing, this is
all
not
burning.
cryo.
Right.
Is there a difference? Is there,
So cryo point ablation is a nightmare because it would take us a whole day to do it. I mean, it's just, because it doesn't work well. It's not as effective, but cryo balloon, which, was, I had some slides in there, but I hit them. That's a good, it's a good procedure for actually paroxysmal atrial fib patients, and we as a group decided not to do it because, at that time there was a lot of complications with phrenic nerve injury and the left, because you have to put it all the way in the vein.
Oh, okay.
And on the right superior pulmonary vein, you know, that phrenic nerve is on there, so there was a lot of paralysis with that, 10 to 14%. And then and it's very expensive in the sense that you have to pull another catheter out if you have a flutter ablation that you need to do. There's not much benefit as far as success rate, that sort of thing. I mean, there's not, so it didn't seem like it would be a better procedure to do. Was that okay? Did you guys?
Yeah,
okay.
yeah, it was
So we
great.
have a
We
very
learned
awesome-
something.
okay.
Yeah,
Okay.
thank you so
Yes.
much.
Yeah.
And so
Alright.
we have our first, we'll start, go live on next Tuesday
Okay.
with, the recovery.
Okay. Let me ask you a question. What have you guys decided about the sheets and pulling the sheets?
We're gonna pull them on the first case.
Okay. How do you feel about, you know, because the way we do them in the room is that they're still asleep.
I know.
And it eliminates a lot of the vagal things. And so I'm just worried about pulling them while they're sort of awake and having vagal episodes which look just like a tamponade type of thing. And then you start getting echoes and this and that. You start, you know, just a lot of things to worry about. That's one concern I have about that.
Okay. I mean, if you guys, we were just doing it to help with.
Yes, yes, yes.
Turn
No,
off
no,
the
no. I
phone.
mean, I think that really helps because, you know, they sit there with ACTs. So, but
Well, it's, you know, I tracked how much time from end of procedure to the time that the procedure is technically ended till the time they roll out. For 4 months I did, and the average time is 40 minutes. How much time they actually
Yeah.
spend still in the room
Yes,
once you
I'm
consider
sure.
the procedure done.
yes,
Getting
oh, yeah.
sheaths pulled and
Yes,
all that kind of
ACT,
stuff.
drawn, yeah.
it's an average of
Correct.
40 minutes.
You think it's gonna be just based off of the case? You guys can just assess at that point if you guys wanna pull it
Right.
back
We
there
could
or.
switch them to shorter sheets. Is that what you guys?
Right.
That's
That's
what
what
they were gonna
prefer.
do that.
That's, yeah,
Okay,
that's what
'cause,
they're
yeah,
gonna do.
those long ones. I mean, I can't imagine somebody wouldn't bagel with
Oh,
something like this.
No,
long coming
yeah,
out of
we
their
wanted
mouth.
the shorter,
Yeah.
the short ones.
Did you say we're pulling sheaves on the first
Yeah.
AFib case of the day
Yeah.
in the lab, in the holding area?
Holding
And
it.
so when
We're
they
short,
have
but the short
multiple
sheets. so
sheaths
that's what
in a
we bring.
room, which they do,
Yes.
I mean, I've never watched them do it in the room, but do they pull them all? If there's 3 of them in there, they pull them all kind of at the same time?
Every one of them does something differently.
Slightly different?
Yes.
And?
And see,
Can
we
you
have a
speak to that?
practice in the, cause we
They do
pull
it,
sheets, we
each
like that.
person does it different, some will pull
Yeah.
all
Experts in
at one
sheath
time.
management.
Yes.
So we don't pull that way, you know,
Yes.
not all at one time.
And there's not a
And you don't
way,
have to do it that way. I mean, you
Yeah.
can just talk to, I don't know honestly what they do. They do.
I think Trish is trying to get them standardized. She came from the holding area.
Yes.
So she is, basically, she taught them how to
Okay.
pull sheaves the whole.
So you'll
she's
need
teaching
the,
them.
you'll need all the stuff that they use in there, you know, what
The
are they called?
safeguard-
They
yeah,
change
we-
names all the time, the
They-
little patch things, what are they called now?
Oh,
the
yeah.
D-stacks
The
or
D-stack,
yes,
Neptune
yes,
or whatever
yes,
they,
yes,
yes, yeah, we
whatever
have
they
all
call
that.
it,
They
yeah.
put and they put the safeguard on.
Yes. the
Um,
safeguard.
But
Just
there's
put
not if you pull them all, like, if you pull Art and Venus together, you know, you can get that AV fistula.
Yeah, it's not a
there's
good
not
idea.
a
No,
arterial.
that
there's
needs to
not
be
an
No
in-
arterial.
I know, no, but you can't get that if you pull veins together.
No.
There's not, there isn't enough pressure to create
Right.
that
So
fistula, right?
usually you
pull
have 3 on the right, I mean, I don't know what everybody has. I have 3 on the right side and 2 on the left side. And so I've seen them pull this side, like pull, you know, make sure there's
Right.
no clot, whatever, you guys do all that,
Right.
flush the sheets. And then pull the next one, like sort of do it one at a time, not like this, you know, not pull them at the same time. That may be better. I mean, just talk to Trish and see what they do.
I think she pulls like, Sandy, she'll pull like one and then go ahead and pull the other one.
Kind of,
Yes.
Mm-hmm.
right,
One
right,
side
every
back,
part.
back from
Yeah.
each other.
Mm-hmm. Well, you will
I've
ask
seen
And
her.
then the pressure needs to be a little bit different than arterial.
Oh, yeah.
Because
Well,
it's
sure,
bruised.
'cause they're
Yeah,
bruised.
'cause it's venous, so
Yeah.
just, she knows about that
Yeah.
bruising
And
and
I've seen where one's on one side pulling and they have somebody else on the other
I was
side.
gonna-
yes,
I know.
that's the other thing,
Yeah.
maybe.
They pull, yeah.
That way you're not,
You're not spending
20
40 minutes.
Yes.
Yeah,
yes.
exactly. And that's why everybody went to that core class, because I told you guys I want people helping that PACU nurse with the pulling part.
Yeah.
So, yeah. The main thing is just switching them out to the Saxonhouse to the
Yeah.
shorter one.
We'll
So they
have to,
won't
yes,
come out
because
there.
the long ones are, that's, and if anybody saw that coming out, if they're awake, forget it.
So, Dr. Saxonhouse,
Pull it out
what's
of me.
the incidence though? Because we pull art lines all the time with these people that just get a little bit of moderate
Right.
sedation, and they don't vagal.
Okay, so for some reason,
So-
we did this, where I came from, Florida, we did a lot of atrial fibrillations. And we had 2 rooms doing 2, so they all went out to the holding room. And, we had so many, I mean, their atropine was at everyone's, like, you know, this
Really?
little cart that comes out.
Yeah.
Like you put, that you put like their chart and stuff on, there's always atropine because it happened all the time. Cause it's a lot of them and you're doing 2 sites and, I mean, I don't know what it is, it's just,
Okay.
it just happens. And it's the kind of patients, they're not vascular patients like the coronary
Right.
disease patients, they're more younger, healthier people that would tend to vagal.
With the pressure on the
Yes.
groin kind
Yep.
of thing.
So make sure it's not, we're doing
So maybe we
these
need a lot of
pressure.
atropine, boxes around. That would be that's.
Well,
these are part of
Put the patient in for our nurses.
We don't be pushing it like a bacteria.
One of us is going to the lab.
First
It's a
one
day.
that's
Yeah.
Yeah, you were like,
Rather do
And
that
I was like,
instead of bringing
Cause
it
it's
up.
No.
natural.
I mean, I
And
wasn't,
then,
I wasn't
then
expecting
they
it, and I
cough
wasn't
with
told.
the extubation. Sometimes they are asleep still when they pull them, so.
Yeah, I'm not against going back there and pulling them.
Whatever's best for the patient.
Yeah,
exactly.
I know
We'll
who's
see,
working
I
out
guess
gonna
we'll
be
see how
asleep.
it works
How
out.
it works out.
right, yeah, I
We
guess
may
we
have
can
to
see.
tweak the
Process, if they want us to come out there, or if they wanna still pull. Can you just have
Talk
to
to
see?
other centers, like, to see
You
what
got the
they're doing.
CRNA back there.
And you can, do you have any contact with
Mhm.
Duke? I know they do a lot of AFibs as well.
Yes. I
And
will.
they do